He is the Senior Vice President of Medical Affairs and the Chief Medical Officer at Northwestern Medicine Central DuPage Hospital, our friend Dr. Kevin Mose. Good morning to you, sir.
Hey, good morning. How are you guys?
Well, I think it's almost time for you to ruin Thanksgiving.
I think we do that next week, right?
Yeah, we're getting closer.
Yeah.
We're getting closer.
So just eat everything now for the next week.
But before Doc ruins Thanksgiving, we have many things to discuss, including many listeners who want to know what Jane's about to ask you. Jane.
Well, we've heard a lot about these weight loss drugs like the Ozempic, which has that tirzepatide, and now this Wegovy, which is a different ingredient, the semaglutide. And I'm saying these things wrong, but Dr. Most will not. But this, the Wegovy now says it has heart health benefits.
Yeah, how about it? You know, and obviously these have just taken the country by storm here over the last 5-6 months, and really right now they're really hitting it hard. And certainly each of them has the benefits of the weight loss. Matter of fact, the weight loss is pretty substantial. Upwards of 20-25% people can lose their weight. And in a country where obesity and type 2 diabetes is rampant, certainly the weight loss is very important. But probably more importantly, the study that you're talking about that just came out this past week that showed an actual increase in the benefits for heart protection with the same drugs. So decreased number of strokes, decreased number of heart attacks. Now, it wasn't dramatic, but it certainly was substantial and certainly was noted by the medical community.
Well, my question would be chicken or the egg here, right? Because if you're losing 25% of your body weight, that would help your heart.
Exactly. And you hit it right on the head. Two things happen there. One, if we're controlling diabetes and decreasing diabetes, that decreases our rate. If we're decreasing our weight, it decreases the risk on our heart. So it's not surprising that this occurred. Mm-hmm. It's just another thing that people are going to say, wait, you're at a high risk for a heart attack. Your BMI is 26, 27. Boy, I'm going to put you on this drug. Versus the people that we're really looking at, with much higher BMIs, just looking at the weight loss, doctors are going to start looking at the health benefits, the heart benefits. But it's going to be pretty pricey for a while here.
But sometimes it sounds too good to be true. Like all of these amazing miracle drugs are making me skinny. I mean, there's a certain type of person that should be on these, and then there's people who want to lose 5 pounds, and that's not something for you. My concern is the effects after it down the road years later, and we don't know that part yet.
Absolutely. You're talking about a brand new drug, a brand new class of drug, and there's going to be others coming out here very shortly. I mean, the pharmaceutical companies have focused on weight loss. They know that the impact that the drug would make on that. And you make two good points. One of them is the side effect profile of this. You have to be careful with that as well. So it's not like, I'm taking this and I feel great and everything. You got to be careful. There's individuals who have had essentially stomach paralysis, so that their stomach, just kind of fills with food because it's not moving well. There's people who have colon problems because of it, and certainly the long-term effects. And the long-term effects of the drug is one thing, but are we going to teach people after you've lost the amount of weight you want, have you also changed your lifestyle? Or is this going to be another, I'm going to go on a diet, or I'm going to take this medicine, and now I'm going to put the weight back on, I'm going to take the medicine again.
All right, three-parter here on blood pressure, then we'll jump to a list of things to hit in our time with Dr. Kevin Mose. Blood pressure, what is the new standard? What are the numbers we need to hit?
Well, blood pressure is really a discussion with you and your doctor, and it's really important that you do that.
Well, you're my doctor, so I'm discussing it with you.
Yeah, I know. Yeah, for you.
Look, you drew the short straw. Stop whining. What is the number?
So really, the ideal blood pressure is like 120/80.
Okay.
Used to be, we looked at 140 being hypertension. Now we're really starting to look at the blood pressure being much lower, but also looking at the ages. So as we age, certainly we're going to look at adults, a little bit differently than we look at children. But certainly, the old 140/90, those days are gone. We're going to be starting to be more aggressive in treating especially that systolic number, that upper number, which does the damage to the vessels.
So that would be something that ties nicely into something you've advocated for a long time, and that is to watch your blood pressure at home, even on a daily basis. Do a quick blood pressure check. At what age should we start doing that?
Well, I'm a huge fan of doing it in their 40s. And you say, gosh, doesn't that seem young? And I'll tell you, people who have a history of family heart disease, do it in your 30s. It's much easier to keep your blood pressure under control when you start early than it is later when you're like, okay, my body habitus is where it is, my diet's where it is, my exercise pattern is where it is, and now my options are to screen but also take medication. The goal for anybody should be to keep your blood pressure to a point where you don't need medication, and that's going to be with exercise and activity and eating properly and monitoring. So really, checking your blood pressure is something that is so simple now, so inexpensive. It's a great Christmas gift, and something that's really going to impact the entire family's health when you can all use the exact same machine.
Yeah, just keep notes on your phone, whatever the case may be. When do you need to see a doctor? If you get 3 or 4 bad readings in a row, what do you think?
Yeah, and it's interesting the way you said that too, is, keep track of it, because a lot of people have white coat hypertension. They're, oh my gosh, I'm late getting to the doctor's office. I don't want to go to the doctor. I think he's going to give me a shot. What's he going to tell me? My blood pressure is certainly going to go up. So the reading in the doctor's office is often, I don't want to say inaccurate, it's an accurate reading, but it's not what's going on in your normal life. So certainly if we take a blood pressure check anywhere, one time does not equate to high blood pressure. I don't care what the number is. So we say 3 consecutive readings that are high is going to be something that we're going to be more concerned about. So individuals should really be checking at home, taking it, keeping a log of it, and bringing that log into their annual physical, or bring it into the next time you're going to see the doctor.
All right, let me jump to some things that are ever present in our world and worthy of discussion. Kids' vaccines: measles, mumps, rubella, tetanus, pertussis, polio, chickenpox. Everybody gets everything?
No, I wish everybody did. One of our concerns is that pre-COVID, we did a really good job of vaccinating, especially, kids going into kindergarten. We had almost every state over 95% as far as, full vaccination with a very low exemption rate. And what we're seeing now post-COVID is that that's not happening, and the exemption rate, unfortunately, is starting to increase. We have some, areas in some states that, exemption rates in, like Idaho, 12% of kids are having exemption rates for vaccines. Well, I'm sorry, that's just a disaster for diseases that we don't see that much running rampant again, whether it be measles, mumps. Look at the NHL with the outbreak of mumps. Look at the pertussis outbreak in Iowa a couple years ago in the colleges. So we know those diseases are still out there. The way we protect ourselves is to make sure that the large portion of the population is vaccinated, and that can't be more true in that age group than kids.
When it comes to these vaccines and families that don't want the exemptions and want to keep their kid protected, how do they make sure they're on board for that? Is that the doctor's office job or your job?
Well, it's a little bit of both. It's interesting. Parents who are anti-vaxxers, you need to understand the impact that you're going to make on your own child as well as the children and the people around you. And I'll tell you, I get frustrated with people who are anti-vaxxers. I think we've done enough to show the impact and the lives we've saved and the pain that we've saved in children. You look at measles, mumps, rubella. I'm sorry. People have to understand that kids can go blind. They can die. They can get encephalitis. They can have heart issues. We know.
Well, and polio just didn't go away.
Correct.
Right.
Correct.
So,
look at polio. Polio's, I'd love to say it's eradicated. It's not. There's still anywhere from 50 to 100 cases in the world, but essentially we haven't seen a case of polio since 1993, except for someone who traveled in with polio. So we're very good on some illnesses that make a huge impact.
we come back, we will discuss, amongst other things, a rise of strep throat, antibiotic use. Are we any better at managing that? What pain treatment could be impacted by? Kind of a cool story. There's a little bit of COVID news. And Doc will tell us how much Wegovy costs, and we'll give it away to the seventh caller.
Wow.
What? No, that can't be right. 6:47. I'll be fired during this break. Yeah. But first, I'm back on the Steve Cochran Show, show number 307. Dr. Kevin Most is here. You guys lock that line down for me so we can put Dave on. Dave has a question, Doc, about weight. And I think this is interesting. Muscle weighs more, right, Dave? What you gained? How much when you went to the gym?
You know what? I was 145. My girlfriend told me I was too skinny. I needed to put on some weight. I was concerned. I'm 63 years old. I was 55 at the time. I felt good, but you know what? I put on 15 pounds. I got up to 160, and I looked a lot better. I felt a lot better, and now my primary is telling me I'm over my BMI number. I think that's what it is, and she's concerned that I've got a little bit too much weight.
Doc, your thoughts?
Well, we always think that muscle weighs a lot more than fat, but really what we're looking at is how your weight has changed and how has it improved your health. So, I mean, I look at it and say, the BMI is kind of out right now. It's not a number that's being chased, but certainly looking at your BMI, looking at your muscle tone, because as you age, I think you said, Dave, you're 63. What we want to do is we want to build muscle mass in these individuals. We want to build bone mass in these individuals. So as long as you don't have a lot of fat around your middle section, your adipose tissue here in the stomach, really you want to go and be more fit. Then I'm concerned about your weight at that point.
And if he says he feels good, that's a good sign.
Well, and that means he's more active. He's doing things. He's out and around. So very good. I would say, don't chase the BMI number. Really look at your weight and look at your stamina and look at how much you're doing as far as an exercise program.
Cost of Wegovy, cost of these weight loss drugs, prohibitive?
Well, it's interesting. The cost, when we saw it was like $1,400 a month, and we're like, wow, that's going to be crazy. What we're seeing is that actually some insurance companies are covering it, which is very interesting. And what's probably even more interesting is, as Jane brought out, the heart benefit, you might see more companies start covering it. There's some companies that are covering it so it's down to $25, $50 a week for the injection, so $100 a month, which is still a lot of money, but a lot less than, the $1,400. So certainly it's going to be something that's going to be in the news. These companies can't make this drug fast enough, which just shows the demand for it. They expect that there's going to be a shortage for the next 3 to 4 years.
Dr. Most, let's talk about a childhood favorite, strep throat. It's on the rise with kids that obviously, what are you, like 5 to 15, you're getting strep throat even into college. But amoxicillin, there's a shortage of that antibiotic. Is there an alternative that doctors are going to, or what are we doing about that?
Yeah, it's a really good point. Strep does rise while we go into school, so we're going to see more cases of it. But actually, the concern is exactly what you said. Amoxicillin, the most popular drug for it because it's generic, it's inexpensive, and kids like the taste of it and will take it. What we're seeing is that the powder, so the suspension portion of it that young kids have because they can't swallow a pill or the dosing isn't, the pill dosing is too much for them, that's where the shortage is. So the biggest message to parents is if your child is diagnosed with strep throat and your doctor writes a prescription for amoxicillin and you go to the pharmacy and they say, we don't have it today, we'll have it in the next couple of days, no, please go to another pharmacy because we really want to make sure you treat that as quickly as possible. There's no shortage on the pills. The shortage is all in the suspension, but that's really the kids that we're really the most concerned about. So watch it and don't take no for an answer. And if the doctor or if the pharmacy doesn't have amoxicillin, you can always call the doctor because there are other drugs that cost more but that are more available.
Is it not? Couldn't you just mash up a regular pill, or doesn't it work the same way?
Yeah. It doesn't really work the same way, and the dosing accuracy is probably our biggest thing because we're dosing by weight with kids, so we're getting very exact as far as how much we want to give them. That's why we use syringes to give young kids the amount of medication we want.
Nick and I are starting a pharmaceutical juice bar. Because we're doing smoothies, amoxicillin smoothies. That's a hot one. And put a little strawberry and banana in that. And boy, next year we're really looking forward to our COVID smoothie. Right?
Yeah, I bet your investors are just lining up for you guys.
Well, not yet, but we haven't shown them where the line would form. Airports are testing for COVID.
Yeah, they are. We talked about this briefly a little bit last week, because we're starting to expand the number of airports that are testing for COVID. But now what we're looking at is now airports testing for more than COVID. You're going to start that. We're going to start looking at them testing for influenza, testing for RSV, and actually within the next year, testing for up to 30 different bacteria and viruses. The world's getting smaller. We have to understand when outbreaks are going to happen. And this is going to be the surveillance of it. Right now, it's by volunteer. You're altruistic. You walk off the airplane and say, you know what, I'm more than happy to be tested. And then we're also testing the wastewater from airplanes. So we're going to have a much better idea of what illnesses are here, where they're coming from, and how they're spreading.
And important, last but not least, and I love this story, there is a correlation between pain relief and music therapy.
Yeah, Jane, this is a great study. It came out of McGill University. You know, we always think, play soothing music, and that's going to help people with pain. And what they found is that didn't help at all. But what they did find is that people who have their favorite music, that really helps with pain. So, you know, they took these students and they said, hey, you know what, we're going to do this thing where we're going to cause pain, and we're going to play music. Some didn't hear any music, and they rated their pain. Some had soft, you know, comfortable music, and they rated their pain. And then others used their favorite music. And what they found is those who were listening to their favorite music had a drastic decrease in their perception of pain. The emotional portion of music there. And we're starting to find that more and more in hospitals where, you know, we're trying to stay away from pain medications as much as we can while still relieving and keeping people comfortable. And that's why music therapy is getting to be so popular in hospitals.
Is that because it releases some sort of hormone in your brain, like a serotonin, a happy hormone?
Mm-hmm. Yep, the endorphins and the serotonins, you're absolutely right. You know, those are the ones, and they bring back those memories, and they bring joy to you. And it's
But you should control your own pain playlist, right? Because the problem is, like, if I'm in pain and you play anything by ABBA, I'm going to be in more pain.
Yeah.
Correct. I think you'll start to see that with patients coming in the hospital saying, you know, bring in, you know, whatever, your Spotify or whatever, and we'll play it here in the hospital for you, you know, while you're uncomfortable. So I think it's just fascinating that they've gone to that, because it used to be, play some soothing music while we're doing this. Well, that did not pan out. That didn't really decrease anybody's perception of pain.
I don't want to be in the hospital, but if I am, I'm just going to play Brick House on a loop.
Yeah. You would, too.
Doc, you're the best. You know that, and we appreciate it very much. All the best to you, the fine folks you work with and the folks who work for you there at Central DuPage Hospital and Northwestern Medicine. We thank you.
You got it. We'll talk soon.
Thanks,
There's
Dr. Most.
Dr. Kevin Most.